Good evening. I believe we're now on air and we're double checking since we had some difficulties last go around. But welcome. I'm Tony Puente, and I am going to provide the third of three workshops, or mini workshops, if you will, on the CPT system. And the focus today is going to be on testing, both psychological testing and neuropsychological testing, although because of some requests from several sources, I will also be talking about the health and behavior codes, at least relative to assessment. So thanks a lot for being here. I appreciate you taking your evening to discuss an issue of great importance. We have several slides, of which many of these are found in psychologycoding.com. We are going to be revising it in the next few days based on some new information that's come out of CMS that warrants us considering a different view of several issues. But for right now, what we have is the latest and hopefully the greatest. So with that, I'm going to switch from my face to the actual screen share. And I think, by the way, that unlike the last one, which we were not in a position to have the greatest technical advancements in good form, we have everything squared away. I apologize for those of you that were at the last one, but I was in a facility and I was not in a position to have the everything set up as nicely as we have it this evening. So with that, let me turn over to the screen share, and hopefully you will see the slides. And again, as you can see from the bottom of the slide, we have psychologycoding.com. And I will tell you that I revised these slides as of 4 o'clock. This is the best information I have available at the present time. So, as with every other presentation I've made, there's this disclaimer that basically says I'm giving you the best information I have available, but when it's all said and done, this does not represent anybody's particular views, including the APA and other associations, what you can see there. And even though I'm trying to do my very best to give you the latest, you are ultimately responsible for the application of this material to your professional practice or perspective about how psychology might work. There are many people that have been involved in many organizations. I want to give kudos to several of them. Probably the biggest ones are North Carolina Psychological Association, the American Psych Association, the practice director specifically, and then the AMA, the CPT staff, and the National Academy of Neuropsychology, Division 40, CMS, and National Academies of Practice have all been very supportive as well. As far as individuals, probably the biggest ones are Randy Phelps from APA, also Norm Anderson, the CEO, have both been very supportive, as has Catherine Nordell. However, individuals that need to be mentioned include James Georgilakis, or Jim, and Neil Pliskin. They've been, in many ways, individuals in what we sometimes refer to as the band of brothers, in hoping and doing our very best to keep psychology alive. Support has been provided from time to time. It's very, very simplistic. I have my my airplane and meals paid for as a rule. If anything else comes out, which is far and few between, it goes to the university as stipends for the graduate students to help fund the free clinic that we staff, as well as the research that we do. I've been involved in this since the late 1980s. First started with Sally Cameron and continuing through several groups, including the NANS Professional Affairs and Information Committee, which is now run by Teresa Roebuck, and several other groups that you can see there. Most recently, the last one, and probably the most important one, is my continuing work with the AMA CPT panel itself. It's important, and I've said this on a number of occasions, and I hate to bring it up one more time, but let's do, and that is that there are standards that need to be understood. That involves the APA ethics, all HIPAA federal regulations, your state and provincial licensure requirements, professional standards, including the I hope soon to be published standards for educational psychological tests. That may be published, it may be available at APA. So look for that in your newsstand, so to speak. One of the things that I often mention, I want to emphasize again today, that when it's all said and done, all these things in many ways are trumped by the contractual agreements that you and I have signed. And very often the information is not clearly borne out, often found in specific portions of a website. So you need to appreciate that all things being equal, you should follow the ethics, the HIPAA, the provincial and state licensing requirements, but you need to be equally attentive to contractual agreements that you, or for that matter, the facility that you are employed by, have signed. Which leads me to give you one very generic slide, and that is, when it's all said and done, everything I give you this evening is my interpretation of federal guidelines. When it's all said and done, the local review, the actual policy of the contractual agreement that you have signed basically trumps everything else that I may have to say. So if I suggest, for example, that testing can be done with a technician, and your particular insurance company believes that that is not possible, and you have signed a contract that says that's not acceptable, or you happen to live in the state of New York, that poses some challenges for you as to how to proceed further with the use of a technician. So what I have to share with you one last time is federal, national, and in many ways aspirational. Almost all insurance companies, probably as far as I could tell, decrease these national standards and adapt them in a more specific way to make them more applicable to what is it that they need themselves. All right, so we have approximately 12 different sections in our evening's presentation. And the first, and by far the largest one, is the current procedural terminology. The others are small, but still supportive of the testing issues. But the biggest one is, without a doubt, the current procedural terminology, the overview. Okay, and let's jump into that. All right, so first, and maybe foremost, this is all copyrighted material. This is done with the in conjunction with the American Medical Association and its relationship with CMS, Centers for Medicare and Medicaid Services, and this is copyrighted material. So there are approximately 8,000 codes, and of those codes, maybe 60 are applicable to psychology. These codes are found in the psychiatry, which is the original section that psychology worked under. I guess you could say that these are the mental health codes. We then added the biofeedback code in the mid-1990s. We then proceeded to add the large paradigm-shifting central nervous system assessment codes, which we'll talk about extensively today. I won't talk much about physical medicine and rehabilitation. I will say a few words about health and behavior assessment. I will not address the issues on Teen Conference, but I will mention something about evaluation and management as well. So the primary focus will be on the CNS assessment or the testing codes, but several other areas will be attended to. Just to put it in perspective, these 8,000 or so codes are then divided into approximately 16 or 17% of the gross domestic product of the U.S., and that is how people make their living. Somebody asked me the other day, if I could go back to that original slide, actually, I think it was over the weekend, or yesterday, I'm sorry, I received an email from one of my colleagues that said, what is CPT? Well, CPT, in fact, we have a new postdoctoral fellow here from Mexico, and she asked me that earlier as well. What is CPT? Procedural terminology, which essentially is, in a nutshell, everything involving how you should, let me rephrase, what you can do in healthcare, roughly speaking, how you can do it, how you document it, and how much you get reimbursed. So in essence, this is, in a nutshell, a paradigm for the provision of healthcare in the U.S. by design, or maybe I should say by default. It's becoming the system of doing business in healthcare in the rest of the world. It's a very complicated system. I gave a webinar back in May, I believe, and that is found in the psychologycoding.com website. I encourage you to take a look at that, and of course you can look at the AMA CPT website as well. But just to summarize, CPT is the system that the federal government and the largest group of healthcare providers in the world, physicians, have agreed to as what is acceptable to what can be done, how it should be done, how it should be documented, and how much you should get paid for it. So with that, let's move on. All right. So in terms of CNS assessment codes, which is the primary focus, a lot of people were asking and have asked, why did you change the codes? So this is a somewhat historical slide, but there's several issues. First of all, we had to. It's one of those things that we didn't have a choice. CMS said you had to. Second of all, we did not have a technical code. As a matter of fact, one could argue that we didn't have the opportunity to use technicians. And finally, that there was the issue of cognitive work. In essence, until this set of codes were set up, the way that CMS, and for that matter AMA, psychology to be, is that we're primarily technicians. We were not cognitivists, and the reason we're not that is because we were not part of the 1989 Social Security Act, indicating that we were physicians, with the hope of realizing or encouraging people in government to understand that we were, if you will, different than physicians. Unfortunately, some of us did not understand that according to the federal government, there are two kinds of people, technicians and professionals, and by excluding us from the list of physicians, we essentially became non-cognitivists, which essentially meant that we got reimbursed entirely on the practice component. So in many ways, opening up to the system of testing was critical because of a multi-dimensional set of factors, and I think all things being equal, it turned out to be much better than we ever anticipated. I should share with you, especially for those of you who've been around the mulberry bush enough to appreciate how much you were getting reimbursed for the old 96117 before we had a technician code. Keep in mind that the reimbursement in those days for the testing code was essentially roughly equal what the reimbursement is today for the so-called technician code. So life has not gone for the worse in terms of money or, for that matter, clarity and technical, or if you will, professional, if you will, more specifically, how things were supposed to be measured. So with that in mind, let's look at the codes that I'm interested in talking about. I'm not going to be talking too much about the codes in between the neurobehavioral status exam, although I will refer to them later on. I am going to be referring to psychological testing and neuropsychological testing a great deal. I do want to point out, and I wish I had a pointer to alert you to this, and that is the 5 units for psychological testing and the 10 units. Notice the word or the abbreviation EG, example given. We have been made available the information as to what is the typical amount of units allowed for these test codes. We are by agreement bound not to reveal those numbers, but I will tell you that psychological testing is a bit lower than neuropsychological testing, and I'm giving you some examples of the ballpark figures that CMS and the American Medical Association consider to be typical. This really comes out from the work of a National Correct Coding Initiative, and specifically the work of Niles Rosen, who is the chief medical officer for that group. A very nice individual, willing to hear our concerns and, for that matter, our complaints. All right, so I will say this real quickly. I will mention it again. A testing code, as a rule, except for health and behavior, does not occur unless 31 minutes actually is transpired. So with that, let's jump into great detail about each of the testing codes. First of all, this is 96101, psychological testing. You can read the slide yourself, but I want to emphasize several things. First of all, notice the EG. This is an example given, MMPI, Rorschach ways. So this is a group of tests that are, roughly speaking, involving assessment of emotionality, intellectual abilities, personality, and psychopathology. With that in mind, I want to emphasize the following. It's per hour of psychologist or physician's time, both face-to-face with the patient and time interpreting test results and preparing the report. This is these numbers that I'm giving you are a little bit outdated, about a year or so, but the last time that I looked at this, there were 175,000 claims for this particular code. Now, as you see in this particular slide, a 101 is reported by the physician psychologist with subsequent interpretation report. It is also reported for the integration of information obtained from other sources, which is incorporated into the actual context. Okay, let me explain what this means. This essentially means that this is, in some ways, the code that you use for psychological testing that involves both the test administration as well as the interpretation of that in conjunction with other things. So, as I'll mention this one other time, when you are bringing together information from other tests, from the history, from behavioral observations together, and you're generating a document, if it's involving a psychological condition, that activity, as well as the administration of the test itself, is 101. Furthermore, if the test is being administered and scored by the professional, which is broadly defined as the individual who has a contractual agreement with an insurance company that's paying for the service, then that individual can bill for testing, scoring, integration, and interpretation of these findings in a broader context. If, on the other hand, the testing is done by another party, you have to use 96102. Psychological testing of emotionality, intellectual abilities, personality, including, as I've said before, MMPI, Rorschach, and the ways, with qualified health care professional interpretation administered by a technician per hour technician time, face to face. I will address later on in our presentation this evening as to what a qualified health professional interpretation is, and more importantly, what a technician is. However, it is critical that you appreciate that when a technician is being used, as in the case of 102, that in this particular case, the technician can only bill for face-to-face time. The assumption is that face-to-face time is primarily for the administration of the test. So, by default, selection of the test from the cabinet, scoring of the test, and things of that nature cannot be billed. However, don't worry. This activity was taken into consideration with the vignette that was originally used to value the code. So it's not like it's not being attended to. It has been factored in, and that's one reason why the code is reasonably reimbursed. So to go in a little bit more detail, as you can see, this is done by a technician under the supervision of the professional. The tests are selected by not the technician, but by the professional. The technician essentially does what the so-called qualified health professional requests. They are, if you will, a physician or healthcare extender. If, on the other hand, a computer is involved without the use of a third party, then that is 96103. Psychodiagnostic assessment of emotionality, intellectual abilities, personality, and psychopathology. In essence, what that is essentially an MMPI that is administered by the secretary in front of a computer, and the secretary at the end of the session presses the button, and now comes a green report, for example, that says, here's the scale score elevations on scale 1, 2, 3, 4, and maybe even what the interpretation of these findings are. The assumption is that that report is placed on the chart of the patient and no integration with other findings, behavioral, emotional, record review, or any other tests theoretically are to be used. This might be the kind of thing that you may want to use relatively sparingly, because those circumstances are not that often. If you are using a computer to test a client, and there's interaction between the technician or the professional and the client, then that does not qualify as a psychological testing by computer. It's critical to appreciate this is an isolated situation. And this is explained much further in the CPT Assistant November 2006 article. If you do integrate it with other things, then the integration is then captured not under 103, but under 101. I'm going to try and bring this all together in much greater detail in a few minutes. But let's go on to talk about neuropsychological testing. In essence, what we have here is nothing more than the cousins of psychological testing. The psychological testing codes are intended for certain kinds of disorder. Let's call them, for what it's worth, psychiatric disorders. These codes are intended for neurological disorders. So to put it again in a very specific way, which I'll emphasize in a few more minutes, the psychological testing codes are DSM codes. These are neurological testing codes. They're meant for assessment of neurological disorders. So, in essence, what we have here again is in EG, Halsted right-hand neuropsychological battery, the Wechsler memory scale, the Wisconsin card sorting test, and so forth, so on. Again, this is an EG, not an IE. And one more time, it has to do with the psychologist or physician's time, both face-to-face with the patient, and time interpreting test results and preparing their report. So, as I'll mention to you on a number of occasions, sorry, I was just trying to get some circulation in the room we're in. Apologies. In essence, what we have here is if the professional does the testing, they can interpret the material, they can score it, and all that's captured. Remember the number that I gave you earlier for psychological testing? It was in the 100,000. Notice the number here is much higher at almost, well, actually, I think at the present time it exceeds 500,000. All right, so to go into some more detail, then again, notice that this comes from the CPT Assistant November 2006 article. For what it's worth, was partially ghostwritten by myself. This is information that needs to be integrated. So if you're integrating the category test with the trail making test, with an FC or something of that nature, along with record material, collateral interviews, and so forth, that integration of information is going to be captured under 96118. And as you can see, 1.8 is involving administration, scoring, integration of this test with interview, behavior, and history, and feedback to the patient. I apologize, I didn't say this under 101, but the 101 and 118 are intended to capture for the professional, one more time, the administration, the scoring, the interpretation, integration, and feedback. The 101 and 118 are intended for both of those activities. Now, again, if you have someone else do the testing, in this case the technician, one more time, actually does the testing and can only bill for face-to-face time. It does capture the additional work involving scoring, but it does so only in the way that we have already surveyed for this activity, and theoretically you're capturing that in an indirect fashion, indirect way. So one is essentially says that the qualified health professional has to gather information about the nature of the complaint, the history of the present problem, based on the clinical history. A selection of the tests has to be made by the professional. The procedures of how those tests are administered are given to the technician, and the technician administers those tests and scores them. If that information, again, is going to be integrated with other things, which almost always it is, then theoretically that integrative activity is going to be captured under the 1.8. The 1.2.0 is the neuropsychological testing by computer. This is, again, when the individual is placed in front of a computer without any oversight. I have to be frank with you. I put down Wisconsin card sorting test because when I was coming up with the descriptor of this test, of this code, I did not know what test I personally was able to administer without having some interaction. Of course, this was in the late 1990s, how times have changed, and we'll talk about this particular code and its unusual growth in the last few years. So as you can see, this should be reserved for situations where the computerized testing is unassisted by a provider or technician other than the installation of the test and checking to be sure the patient is able to complete the test. All right. So computerized tests, unlike the other codes, I've now given you 4 separate codes that are not involving computerized testing, are not time-based. They can only be used once per testing session, and to be used for 1 to multiple tests only once per testing session. So this is quite a bit different. Now, it's not my intention to talk about reimbursement because reimbursement theoretically varies according to insurance companies, but I will tell you that in some of the tests that I use that are computerized, they exceed, that is, the cost of the test far exceeds the reimbursement by most companies of this code. However, theoretically, I'm capturing the interpretation of this code into the other codes as a way to try and get, if you will, a big picture of it. So we have had a very unusual circumstance. In the last 2 or 3 years, the neuropsych testing code essentially by computer has increased unbelievable, somewhere in the vicinity of several 100%, if I recall correctly, something like 400%. And the rise is exponential. It seems like about 3 to 4 years ago, certain groups of people discovered that you could use computerized testing code theoretically, for example, to determine whether someone was, quote, demented. And you notice that the 1.2.0 code now is used about half time by neurologists. So the largest increase in these codes is due to the use of computerized testing by physicians, and as you can see from this slide, primarily neurologists. This poses some interesting questions about whether this is a positive thing for neuropsychology and for the patients that we seek to serve, or is this a way to circumvent and limit the amount of patients that we have? That's better discussed over a rum and coke at the next APA or NAN meeting. However, I do want to mention that sometimes, if any of these codes are less than 1 hour, you can append modifier 52. But the assumption is that most always the code will end up rounding to another number. In this case would be to a higher number or lower number, and I'll talk about time a little bit later on. All right, typically psychological testing codes 101 and 103 And the neuropsych testing codes are administered once per illness condition, or when a significant change in behavior or medical condition necessitates reevaluation. Screening is not reimbursable. Repeated evaluations because you think they may be correct is not appropriate. You should theoretically have an illness condition or a significant change in behavior, or there's a health condition. If you are going to do an evaluation on a regular basis, say for example for dementia every 6 months or 12 months, it may be in your best interest to be careful about why you're doing that and document accordingly to establish, as we'll refer to later on, the issue of medical necessity. There's additional information you can find in the CMS manual, and you see that in Transmittal 55 with a subsequent change in 2006. Subsequent change to request 5204. So take a look at that if you want to get some background information. Now, a few quick words about where this might lie in the scheme of things. Let's take a look at 101. You notice that 101 is used very heavily by psychologists as well as MDs. CP stands for clinical psychologists. You notice also as time goes on that 101, 102, 116, and 18 and 19 are almost used exclusively for by clinical psychologists. I do encourage you also to take a look at the difference between 101 and 118 in terms of the age. Notice that 101 is primarily used as a code for young individuals, relatively speaking, and the 1A code is used by older or for older individuals. Notice that dementia is the typical diagnosis for 1A, and the mood disorder is the typical diagnosis for psychological testing. This particular slide, although it's now slightly outdated, tells you several important things. Psychological testing and neuropsychological testing is almost always done in an outpatient office. Psychological testing is for younger individuals. Neuropsych testing is for older individuals. That psychological testing is almost always associated with a mood disorder, and neuropsych testing is associated with dementia. Now, let's get into an area that's very, very, very complicated. And with that, let me jump into the simultaneous use of a professional and technical code. All right, so here we have the psychological and neuropsychological testing code. So first of all, we have the thing I've said several times, that local carrier trumps everything else. However, you have several possibilities, and the possibilities include the no simultaneous use of a professional and technical code, and the other alternative is that there is no need to worry about it and you can use them both. You could use a modifier of 59, and the question becomes whether you should be using it with the technical code or the non-professional code, that is the technical code. And it appears the modifier is best used for 59, but as straightforward as it seems, this is not so simple. We've been digging over the last 10 years, and we have some additional answers for you. Niles Rosen shared with us that when the provider administers at least one of the tests, then the pre-existing problems with the simultaneous use of two testing codes do not apply. So you may want to consider administering at least one of the tests. This was put out first by Dr. Niles Rosen in 2009, and Regina Walker-Wren, one of the chief medical policy officers for CMS, reiterated that in June of last year. Alternatively, when the professional and the technical services are not provided on the same date, one could theoretically use both of these codes. And two or more codes may be reported on the same date if and only different testing techniques are utilized for different neuropsychological tests. So it's important to know that what these folks are interested in making sure that there is no double dipping. Now, a quick comment regarding 1.8 and 1.9 can be reported if professional administers at least one of the tests to the patient. So it may be useful for you to consider re-administering one of the tests or taking one test that you're particularly fond of, like the clock drawing, and giving it to the patient. In other words, if you are going to administer the test, let me rephrase, if you're going to bill 1.8 and 1.9 on the same date of service, it behooves you to seriously consider administering the test, at least one test yourself. Alternatively, in case you didn't get it, you could, as I see in the previous slide, slide 37, that essentially you have the opportunity to administer the test on one day by the technician and do the interpretation on the other. So I hope you're starting to get a sense that these things can occur, but it's not simple as just doing it. Some insurance companies may exclude the professional technical code simultaneously because there is an internal audit that is often seen, for example, by Ingenix, and many compliance officers in large institutions are still stuck on the CMS transmittal that came out in 2006 that says, in the next to last line of the last paragraph, that this should only occur in, quote, rare circumstances. And with that in mind, many compliance officers are still stuck on that transmittal, despite the CPT assisted article that came out subsequent to that, and despite the fact that almost all CMS carriers are now allowing the use of both of those codes. So in this case, if you are working in a large facility with a very strong compliance program, you may have the difficulty of administering both or billing both 1.8 and 1.9 on the same day, but I've given you some interpretation for that. Modifier 59 is not applicable. So if you are going to use a modifier, the modifier are best attached to the technician or the computer code. All right. If you want more information, Emory University, together with Epilepsy Foundation, asked CMS for clarification on several issues. And in doing so, they went ahead and provided specific responses. And as you can see, there's 7 questions, and they're all out provided for you. However, this basically clarifies what you and I have talked about already, that these issues are essentially doable if specific parameters are provided. Again, there's different interpretations, but we're giving you the best information we have from CMS as well as AMA. As you can see, accordingly, the descriptors for CPT codes 96101 and 1.8 and the parentheticals that follow provide further instructions how to use these codes when additional time is necessary to integrate separate interpretations of a comprehensive report. It is important that you appreciate that the base code 101 and 118 are intended to capture the actual testing and, if you will, the integration. I mentioned earlier, in case you didn't recall, that it also is intended to capture the feedback. However, I appreciate that this poses some problems, and we're working to resolve it. And neuropsychologists integrate separate codes. Can they bill for that time? And if so, how do they bill? Again, you can see that this is intended to capture both the work of the technician as well as the work of the professional. Difficulty lies, to put it real simply, that the code descriptor says that there's interpretation of the report, interpretation of the test. When a singular test or a test is interpreted, and by that I mean a singular test is interpreted under the 1.9 or 102, that is intended to capture the singular interpretation of that test totally out of context with any other information regarding the situation. And with that in mind, in essence, we have a situation that makes it almost impossible for an individual to not capture the professional work that's involved. It's important that you appreciate that the CPT system is intended not to overbill, but it's also intended not to underbill. Okay? The amount of time with the physician and is, of course, captured in the 1.9 code because 0.51 units are associated with the RVUs of the technical codes. What's the takeaway message? Bill for the text, what the texts do. Bill for the professionals, what the professionals do. You can build both sets of code, but how you do it requires some careful attention as to whether you do the test, whether they do the test, whether you do one of the tests and they do the majority of the tests, and what days are the tests actually administered by the technician, and what day is the interpretation and integration of the activities and results put forth together. So if two test codes are to be used on the same day, professionals should perform the administration score and interpret at least one of the tests. You may want to consider using the 59 modifier, and in addition, you may want to simply test one day by the technician and have the interpretation on the others. The documentation of two more codes, I've given you information from prior sources, but this is the best information, and that comes from the Regina Walker-Wren memo to Jamie Schaefer and others at CMS. All right, so let's all bring this together, especially now that we've been involved in this for approximately 45 minutes as we're starting to begin our winding down for the actual CPT portion of our presentation. So if you're doing a CNS assessment, as an example, the neurobehavioral status exam is preceded by any type of testing. And the testing can be done by a professional and a technician or or a computer. The interpretation report writing is done by the professional. It is not done by a third party, by the technician, by the student. It is done by the person who has the contractual agreement with the insurance company, regardless of the quality of the individual that could be interpreted. Now, this is just for heads up. And this is for people who do a lot of testing, especially interested in using computerized testing, or for that matter, expensive tests. One of the things that's been interesting to me is that theoretically, the way that the codes are valued, the practice expense, to be very specific, for the testing codes is that we value the amount of effort and time by the professional, the cost of the overhead, such as secretary, lights, rent, mortgage, whatever, and also the cost of the test. Some tests, as I mentioned before, are extremely expensive. So I've noticed in a recent CPT meeting, the idea of using what we call HCPC codes to add on to the insurance company as a possible way to capture or defray the cost of very expensive tests that require a great deal of capital outlay. This is something that needs to be looked into, and I suspect we will address that in the future. All right, let me talk about other testing codes, because some of us, for example, are involved in dealing with kids. The developmental screening code and its variations, which are coming out in the not too far future, are really intended for a population that's very narrow, and that is essentially a pediatric population. However, these codes were developed by pediatricians with relatively little input by psychologists. So these codes are often qualitative, and some codes, for example, 96110, has no work value. And when it does have a work value, 119, for example, they're relatively small. There's a new cognitive, actually not so new nowadays, 96125. This is the cognitive testing code that is used by OT, speech, and others. This is not intended to be used by doctoral level providers in medicine or in psychology. All right, let me turn our attention to health and behavior codes, because some of individuals have asked to get some clarification on this. The health and behavior are commonly referred to as the H&B code, and essentially require a medical diagnosis. Now keep in mind that these codes are not intended for psychiatric problems. Also, they have 15-minute increments. Unlike all the testing codes that we've discussed up to this point, which are 1-hour increments and can only occur, or if you will, build if you reach a 31-minute threshold, the so-called H&B codes reach a threshold once you go past the 7.5, in essence, 8-minute mark. You have to have 15 minutes, or if you will, 8 minutes to be able to build this code. This is intended for acute and chronic health, or if you will, medical illnesses, is not applicable to psychiatric illnesses. However, they both could be present. They could have comorbid condition. For example, you could have diabetes and depression. The primary diagnosis, however, has to be diabetes. The secondary diagnosis has to be depression. It used to be interpreted by some that if you had any psychiatric illness whatsoever, the H&B code could not be applied. That is completely false and incorrect. Essentially, you can build this code if you have some kind of medical illness and you have had a psychiatric illness, or for that matter, you currently have a psychiatric problem. However, that at this particular juncture would have to be considered as a secondary illness. All right, so what's a code? You would use 96150, and that would be, as you'll see in a second, a number of things, each 15-minute units. However, unlike the other testing codes, the H&B, unfortunately, is only face-to-face. So this is only what you do with the patient present. The initial assessment is coded as 150, and it would not be atypical, and this is critical that you understand, that this could be 4 units or 8 units. So you could spend, for example, up to 2 hours doing this kind of assessment, and if you do that assessment, that would be found as recorded as 96150 times, for example, if it was 2 hours, 8 units, 1.5, 6 units, and so forth. If you are going to do a reassessment, for example, in the hospital setting, you're looking at a patient over and over again, for example, somebody coming out of a coma, you may want to see this person Monday, Tuesday, Wednesday, and so forth. Every time you do a reassessment of that individual, it's 151. So let's turn our attention to the issue of what H&B is all about. It's the identification of psychological, behavioral, emotional, cognitive, and social factors that are involved in the prevention, treatment, or management of physical health problems. This is a focus on the biopsychosocial model of illness rather than a mental health perspective. It could be, and this is a critical slide because people don't understand about the unusual robustness of the H&B codes. This could be an interview, it could be an observation, it could be psychophysiological, or it could be health-oriented questionnaires. It could be anything. Unlike some of the other codes, for example, 101, which is supposed to be psychological test, this is not anything that limiting. It could be simple observation. Now, if the patient requires a psychiatric service, the predominant service should be reported. If you're starting to do a service and they start crying and you do psychotherapy, you obviously have to do psychotherapy. In no case should both sets of services be reported on the same day, especially by the same individual. So this is important to appreciate, that the individual can be diagnosed with a mental illness. However, that mental illness theoretically is not the primary issue in question. Now, people write me on a regular basis, hey, what about this or what about that? What about review of records, completion of forms? The completion of forms 99080 is a wonderful code that nobody reimburses. So these are very typical codes that could be applicable to the type of persons or situations that we work with, but most of these codes do not provide reimbursement, especially for psychologists. However, I do want to turn your attention to a new set of potential codes, especially for those of you who are working on ACAs or new ACOs. They're so-called health behavior screening codes. These are codes that could be used to begin to address the issue of wellness and prevention. Historically, everything that we've done in psychology, or for that matter in healthcare, has been focused on a disease model. For the first time, we're actually starting to focus on a wellness model and get reimbursed for it. So for those of you who are predisposed to this, you may want to think seriously about the idea of branching out from just working with people who are ill to working with people who are well. And these are some examples of codes that you could use to try and screen in an effort to try and get reimbursed, to provide information and feedback to individuals who are trying to maintain a level of wellness versus trying to get out of a disease process, which of course would be found more in the H&B, the neuropsych, and the psychological testing codes. Now, let me move on for a few moments about evaluation and management. This is a holy grail of typical medical consults. As you can see, there's essentially 5 levels. We often refer to as level 1, level 2, 3, 4, and 5. Each of these are very critical in a sense of describing what a typical physician does in case management. This is a combination of assessment and treatment, and this is, I believe, a particularly salient model. If you look at the psychotherapy codes that we discussed in the last webinar and are found in YouTube, you notice that there is different levels. There are different levels for the psychotherapy. Those levels are really mirroring the E&M idea that sometimes patients present with minor problems and can be captured in a problem-focused situation like a 241, and sometimes they really work you hard and you have a high complex situation. I wonder, and I speak out loud on this, just thinking about what the future of testing codes might bring. Might we find ourselves one day in having psychological testing, or for that matter, neuropsychological testing, if you want to put it further, H&B codes that allow us to think about complex testing versus relatively simple testing? Could one argue that a bipolar patient that has frontal dementia, that may have a very complex history, maybe even a borderline, is that much more complicated than a straightforward ADHD evaluation? Well, I think so. And how do we capture those complexities? Maybe the future of testing involves adapting the concept of E&M codes, but for the time being, I don't think that's going to be. So, what's coming down the pike? What should you see in the next handful of months, maybe years? Well, for the summer and fall, expect to see applied behavior analysis, which of course is different than the testing that we've done here. Is obviously an assessment, but not necessarily so much testing. These are new codes that are category 3, very, very, if you will, timely, and could be a big boon for both our patients as well as for some psychologists who work in this area. And in addition to that, we have, I believe, a new set of codes that are probably going to be emerging. Keep in mind, as I said earlier, the so-called computerized testing codes have grown over several 100% in the last year or 2 or 3. And as a consequence, CMS is very interested and concerned. So there is a lot of discussion in bringing forth new test screens that are actually reimbursed, because at the present time, screening is not reimbursed by anything that we do. And of course, the push on integrative care, that's really moving forward. And the question becomes, how do you integrate all the testing information that I've shared with you this evening into a bigger picture of what this means to the entire healthcare or welfare of the individual, not just here's a diagnosis and best of luck. Now here's a coding model that I've shared before. Let me spend a few minutes discussing it. We have 3 different levels. You have psychiatric, neuropsychological, and health psych. If you're doing psychiatric, you're using DSM, the neuropsych, the ICD, the health psych, the ICD as well. If you do an interview, you have the 791. The interview for neuropsych is 16. Interview for the health psych is 150. The testing is 101, 118, and 150. And of course, the interventions are provided as well. Probably one of the biggest things is to imagine that you should not be crossing these columns too much. If you start working in the DSM column, you should stay with it. If, for example, you finish the interview and you believe that it becomes more of a neuropsych, then I think it's appropriate for you to bump over to 1.8 and proceed accordingly. But try to stick with the original column that you start off with. And with that in mind, let's go on to a series of relatively minor topics, of which the first one is diagnosing. It's important to appreciate that there are two diagnostic systems, the DSM and the ICD, and it's also very critical to appreciate that a billing diagnosis is based on the referral question, which was what is pursued as a function of the evaluation, whereas a clinical diagnosis was concluded on the result of the evaluation and may not be similar as to billing or the original working diagnosis. Imagine all the CAT scans that have been done to pursue some serious neurological disorder when in reality they come out to be negative. That's a simple model of understanding what the difference between a billing and clinical diagnosis. We're working on, at least I should say, I'm working on trying to explain this because CMS has written extensively about rule-out diagnosis, and I need to understand that a little further to be able to determine the difference between billing and clinical, and for that matter, ruling out diagnosis. I want to alert you that the ICD is coming down the pike. The ICD-10 is moving further and faster. The original start date has been pushed back. At the present time, it appears to be October 21, 2015. And look at this next slide, slide 68, and you see how the diagnosis for DSM 38.29 is quite different than, for example, the procedure code, the diagnostic code for ICD, which is maybe in this case B01.2, or more likely like 0DN90ZZ. This is going to be a big paradigm shift. As you can see, there's alpha is level 1, numeric is level 2, 3 through 7 is alpha numeric. So the code may be looking like ODB58AZX. I don't know. I think this is very complicated. I'm not sure how we're going to handle this. Hopefully some of you are in the position to lead us out of the woods on this one, because this is going to be a big challenge for those of us who are used to ICD-9, or for that matter, the DSM-5. I wouldn't mind hearing from some of you that could explain to me why the DSM-5 came out on the eve of the release of ICD-10. There must be a reason. I just don't know what that might be. All right, so we've been at this for an hour. Let's jump into more specific things. And one of my more interesting concepts was the idea of medical necessity. There's such a thing as what we might call scientific or clinical necessities, what you think, what the research literature thinks. However, this is not necessarily what the insurance company thinks. What they think is a formulary of a CPT code by DX. For example, 96118 does not match depression. Depression, on the other hand, matches 101. Now, having said that, it would make all the reason in the world for me to be able to deal with or evaluate a person who is very depressed, refractory to treatment, and the clinical psychologist says, I'm having difficulties moving forward with this patient. Maybe there's some underlying cognitive processes that are impaired. That would be a very appropriate clinically and scientifically warranted evaluation, but the insurance company will not pay for that, just like they don't pay in some cases for ADHD evaluations. So, in essence, medical and reasonable and necessary is services which are reasonable and necessary for the diagnosis and treatment of illness or injury, or to improve the functioning of a malformed body member. The reevaluation should only occur when there is a potential change in diagnosis and symptoms. Services which are reasonable and necessary for the diagnosis and treatment of illness or injury, to improve the functioning of a malformed body member. And reevaluation should occur only when there is a potential change in diagnosis and symptoms. All right, let's move our discussions to documentation. I do all this work. What do I have to do with it? I have to document it. If I don't document it, essentially it means I did not do it. If I did not do it, it means I don't get paid. If I happen to have gotten paid and I am audited and I do not have appropriate documentation, rest assured that you'll be fined and you will have to pay back the amount of money that you have been provided. The general principles include the rationale for service, what the procedure, what the result, the impression, the disposition, if applicable, the time, and who did the service and what date was that service. The identifying information, the date, and so forth, so on. I want to alert you to two issues here. Well, let me focus really primarily on one. It used to be that total time was appropriate as a way to describe the time, and I will discuss this again in a few minutes, but it's not the total time, it's the actual time, the start and stop time. And in terms of assessment, please provide identifying information. The reason for service, this is thinly described as medical necessity. Why are you doing this? Because Dr. Smith requested assessment of a child with ADHD, or because there's dementia, what dates, the amount of service, the identity of a tester. Some people like to put the technicians down, others don't. The tests and protocols, including additions. Do not put down the ways. Put down the ways 3 or 4, or as the case may be. Do not just put down the tests. Put down the additions as well. A narrative of the results, impressions, diagnosis, and disposition. I will tell you this, and I'm going to take a little side trip here, at least how I do it. I have two sections. I have a narrative in the report itself, integrated with everything else, which is relatively small, and it says, for example, the score was 68, which places him in the X percentile and gives him a diagnosis, or if you will, a label of whatever the case may be. I don't interpret much more than that. However, every report contains a very complex numerical information, a table with numerical information that in many ways is intended for the fellow neuropsychologist, or psychologist for that matter. So in essence, the narrative in there is intended for somebody who is not a very sophisticated person who understands this information, whereas the numerical values in the table is intended for some other professional who may want to do reassessment or may want to have their own interpretation of the actual data. So in essence, the narrative is relatively light. The table is relatively heavy. Okay, assessment based on interpretation of new codes. You might want to have in your report what section of the report was associated with a technician. So for example, my report and my own forms, I use neuropsychological testing by technician. And the individual test, numerical and basic qualitative information. The professional component is much more involved. It involves integration of findings and so forth, so on. It may include history, prior records, interviews, compilation of other test materials, and so forth. All right, what is time? Time is pre, intra, or post-service. You can think of time as what occurs before the service is done. For example, like a surgeon scrubbing their hands. Intra, the actual activity, such as administration of a test, and post, which essentially means what is done after the service. Okay, essentially, this is the 3 levels. Some things are captured in the professional time, and most of these things, the pre and the post, are not captured for the technical time. Most of the assessment codes are 16 minutes, except the H&B, which I mentioned to you, are 15 minutes. It also involves communicating further with others, follow up with patient or family, and arranging for other kinds of services like referring the patient to a speech therapist, neurologist, the pediatrician, as the case may be. All right, non-face-to-face time, that is pre and post, sometimes is not included in the measurement of build time, but it has been included in calculating total work of service during the survey process for technical services. For technical services. A unit of time is obtained when the midpoint of an activity has occurred. So testing in many ways is not reportable until, for example, in psychological testing, it has reached the 31-minute mark. When a time service is reported along with a non-time service, the two are not added, as in the case of the computerized testing code. Time refers face-to-face, and unit time is when the midpoint has been passed. Do not count time twice, and where multiple days are involved, time is not reset with each and create a new hour. All right, so here's the rounding rule. 1 unit is at least 31 minutes, but less than 91 minutes, and so forth, so on. For quantifying testing, round up or round down to the nearest increment, and use the actual time, not the elapsed time. We are often using, hopefully more and more in our office, starting to start and stop times on the actual tests themselves. Time does not include the patient completing a test, the waiting time by the patient, the typing of reports, and non-professional clerical time, literature searches, and learning new techniques. Now, as far as time, again, it varies according to insurance company, but all things being equal, I imagine that one could argue that for professional, it could be 10, for neuropsych, and probably half that for psych. All right, this is a very complicated issue, and I'm going to run through it largely because it's relatively late in our discussion. But I do want to emphasize some things, and you can find more information in some of the papers, including the first one you see by Malek Hamadi, an applied neuropsychologist, and others, including the Nan Position paper on technicians. A technician is essentially an employee. It requires you to have some kind of contractual relationship, such as a 1099. If the individual is, for example, associated with the federal government, the minimum qualifications happens to be a bachelor's degree from an accredited college or university with some training in the area of social, behavioral, biological sciences. NAN's definition was approved in 2006 and is found in the archives of clinical neuropsychology, an article that myself and several other individuals published. However, and I've said this once before, there is a professional component of the actual expenses associated with, if you will, technical activity, and that is 0.51. That 0.51, which is not that much, includes you selecting a test, determining the protocol, supervising the test, interpreting the test, reporting on individual tests, and assisting with concerns raised by the patient. The qualified health provider must see the patient first. They must supervise the activity and interpret the write the note or report and be engaged in an ongoing capacity. This is very similar to physicians. If the individual is a technician employed at a facility, that's a different issue, and it could be that the code is, if you will, captured on a per diem basis. Students as technicians. Medicare has never reimbursed for student training for any health discipline. The problem, however, is there's an incorrect assumption that the federal government has paid GME or general medical education for training services. It is not. Outside of very unusual circumstances, it does not pay for GME for training of psychologists, and as a consequence, it makes no sense. This is the information you can find from the Medicare Benefit Policy Manual that essentially explains the use of students as technicians. Under the physician fee scale, there is no payment for services performed by students or training. Medicare does not pay for services, including 102 and 119 when performed by a student or trainee. However, the presence of a student or trainee while a test is being administered does not prevent, if you will, from that service being provided and billed by a third party. Now, I do want to say one thing before I move on to supervision. Two things, actually. One is this applies only to Medicare. Only to Medicare. So it's important that students and as technicians, the limitation that is posed by some carriers it's important to appreciate that it's only for Medicare, number one. Number two, if the student is not being your student, is not being trained or educated by you. So, for example, I am a professor at NYU, and the student is from CUNY, and that student theoretically is not considered a student by CMS, and that individual theoretically could be used for Medicare. Of course, that's a bad choice of examples, considering that's the state of New York. Now, what's the supervision requirement? Supervision requirement is you have to have a doctoral degree in psychology, and you have to be licensed or certified as a psychologist. There are 3 levels of supervision: general, direct, and personal. Personal makes no sense. I alert you to the work of Bob McCaffrey about the use of third-party reimbursement and the position papers of NAN and several other associations, including the American Psychological Association, which I was involved with in helping write several years ago. However, I was of the initial impression that it was direct supervision, when in reality it is general supervision, furnished under the overall direction and control. Presence is not required. Activity is directed and supervised by the doctoral level provider, but the provider does not need to be in the office suite. This is a critical distinction that is extremely important. Now, let's turn our attention to this very difficult to read slide on payment. And I wish I could read it more carefully for you. It's too busy, but I do want to, for example, point out 118, which in 2006 was being reimbursed at $129.99, and now being reimbursed a little lower at $89.45. And you're wondering why that is. This is because of the so-called conversion factor, which keeps on going down and down, and this is set by the Congress. I suspect that that will continue to be very, very limited in its reimbursement. If you want more information, you can see that in the Psychology Coding website. The new conversion factor number has been provided by Congress, and it turns out to be very low. Let me take a few minutes of your time this evening to talk about physician quality reporting services, and specifically the potential use of PQRS for certain things. At this particular time, I think there are really 2 areas that PQRS is probably more fit: the so-called dementia cognitive assessment and the screening for depressive symptoms. One of the difficulties is that the dementia screens now have to go through a registry, whereas the depressive symptoms are, if you will, more amenable to alternative reporting styles. The PQRS involves numerator and denominator, and again, you can find that this is applicable to a number of things, including neurobehavioral status exam, as well as the health and behavior assessment. I will share with you that if you're interested in PQRS, you can look at the website, which is found on the CMS, or I may encourage you as well to look at the very important work done by Paula Hartmanstein from Ohio, the Center for Healthy Aging, as well as the work from the PAIC, Professional Affairs and Information Committee, for the National Academy of Neuropsychology. They both have excellent information, but Paula has been our historically been our pioneer in this particular area. If you are interested in PQRS, which if you're doing Medicare, you need to be. Keep in mind that you need to be involved and signed up as soon as possible. We have basically another couple of months to sign up, and there will be penalties that will start in 2015 and will increase. A couple of my peers have suggested the amount of work required to file a PQRS does not warrant the suffering associated with the penalties, and as a consequence, they're not going to do it. But keep it in mind, this is the beginning of a zeitgeist, a paradigm shift, and where we're shifting from fee-for-service to fee-for-performance. The PQRS is the initial step in that particular development, which emphasizes the use of documentation as the first step in understanding the evolution from fee-for-service to pay-for-performance. So this is an interim step, probably maybe phased out by the time we have a true pay-for-performance system, but for the short term, that's the case, so you need to be aware and become involved. Let's talk for a few minutes about the healthcare bill. This is going to revolutionize healthcare, probably the largest singular thing in our history. I equate it with as big as an event as the introduction of psychology to the Medicare system in the late 1980s. I'm very pleased to tell you that I was involved in the initial lobbying for the Medicare inclusion of psychologists back in the late 1980s when I was involved with the North Carolina Psychological Association, and eventually with a healthcare bill development, partially because of my son being involved in that, and also because I was interested in making sure that psychology was well represented. It turns out to be a work in progress because in essence we have everything going down to the state level. The fights are going to be at the state level, and that's where things are occurring. This is a very quick slide that explains to you where we're moving. We're shifting to, as I was sharing with you, a fee-for-service to a fee-for-performance, from a location inpatient to outpatient, from a silo to an integrated approach, from volume to limited and target, to experience-based or empirically based, from independent to a healthcare home. A medical home is what we used to talk about. Now we're talking about healthcare homes. Just the other day I heard about a new idea, and that's healthcare neighborhoods. Just make sure that you're not a cabin in the woods. If you're a cabin in the woods and you're not part of an ACA, you might be, or excuse me, ACO, you may not be in a position to be part of a reimbursement system. That doesn't mean that you have to be in the same house, as I shared with you. You have to be in the same neighborhood, and that's not geographic. You may want to be in the same cyber neighborhood. All right, so what are you expecting? We're working on a prolonged psychotherapy code. The testing feedback is still an issue, and the coordination of care for integrated services is where we're going. That we are going to be working on the revision of codes. The health and behavior codes need to be attended to as well. So you are going to be seeing a lot of changes to 2013, 14, and on to 15. So this is going to be a time of significant change for all of us. Just a few words, as I often do at the end of these presentations. What are we headed to? Well, and I think that we're going to have a stabilization of fees, and the recent work by Congress leads us to believe on the SGR that may be indeed the case. The Affordable Care Act, in my own personal interpretation, as someone who has run until relatively recent a nonprofit indigent multidisciplinary healthcare service. In essence, I believe that is going to be Medicaid light. So we are going to have a lot of folks, like for example, our clinic, Cape Fear Clinic, is going to be living off these Medicaid light contracts. In our own community, some large groups have signed on as ACOs, and they have captured all the individuals from a particular company like Blue Cross Blue Shield, and some of us are going to be left out, and I think they're going to be cherry picking the better patients, and I think it's going to be interesting. I also think that the lowest common denominator historically has been Medicare, and I think that may shift to Medicaid. Now keep in mind from one of the early slides that I said that approximately 2006 or so, about 8 years ago, we were getting reimbursed about $120 an hour for these codes. Now we're getting reimbursed about $90 an hour. One wonders if that's Medicare or Medicaid is a percentage of that, say 80% of that. Are we going to start getting reimbursed somewhere in the vicinity of about $70-some, which of course would be a disastrous circumstance. However, as I've said a little bit earlier, that we're going to be shifting state to state, and we're going to be going from fee for service to pay for performance. We're in the midst of a tsunami of change. The reimbursement system is changing, and I believe that we have, by de facto or indirect, a national health care policy through the Affordable Care Act, and we have, of course, a diagnostic system. Expect new codes of very significant difference in nature over the next 5 years, and then once we get all this worked out, all the different problems resolved, obviously, the way it works, it's that we have one big category test, and they'll shift the set, and we'll have to start learning again. So this is you're in the middle of a very large tsunami, and once the wave is finished and you finish writing and you're exhausted, rest assured that we'll have a new system. But as every other paradigm that has existed, at least in our history, we will obviously rise to the occasion and surf it one more time. If you want more information on this, take a look at psychologycoding.com. There's lots of resources. We've updated the resources. These are all live websites and links. There's quite a few, and if you want more resources in ICD and PQRS, you see them there. And finally, if you look at the psychologycoding.com website, you also have the forms that are available. In essence, you could theoretically use them. You're welcome to adapt them as you see fit. In essence, there are a variety of forms that you could use. I don't think necessarily they're meant to be de facto what you should use, but it might be a way to get you started. If you want information about CPT, here's the data that you could look up. And of course, their APA, the work of Catherine Nordell, and of course now Randy Phelps, should be acknowledged. And let's give kudos to Norm Anderson, who's been very supportive of the CPT process. And finally, if you want to get more information from me or contact me, this is the best way to do so. So with this, I'm going to call my technical assistant up, and let's see whether we can field some questions. I actually did receive questions already, and let's see if I can grab my telephone. And let's see what the first question is. I wonder if this is actually a real question, but we'll still start with this one. My daughter is getting married in October, and I am short on cash. Can I bill for more units than I'm actually doing, largely because the reimbursement system has gone down so much? So can I start billing, for example, 5 or so units more so I can deal with a reimbursement that allows me to have essentially a successful wedding for my daughter? Well, we look forward to corresponding with this colleague from jail. Okay, so this is another question. Is that correct?
Mm-hmm. And you
can okay, so let's take a look at this question. The question is, a training company specifically stated at the Coding for Mental Health seminar that you should not code feedback as 1A, but use a different code. Are there any situation where we use a different code for feedback? I don't know of any. I guess the question I would ask the training company is, where do they got this data from? Now, keep in mind that I said this several times. It's not what I believe to be true. It's what the company says. It could be that some company says, we don't want you to bill 1.8 for feedback. We want you to bill whatever code. If a company tells you to bill X code for feedback and it's in writing, by all means use it. By the way, do not accept verbal interpretations of your questions of anything as valuable or useful. Get it in writing. And if you get it in writing, share it with others, including myself. All right. Could 96101 be billed with 150? Okay, so I'm going to restate the question. Can I bill psychological testing and neuropsychological testing? Probably so. Should you? Probably not. So this is a little different question than you had, but I'm sharing it with you. Can I bill 101 with 150? Probably. Should you? Probably not. Keep in mind I gave you 3 silos, if you will, the mental health silo, the neuropsych or neurological silo, and the health psych. I encourage you not to mix those two. If you have to mix two, excuse me, mix the neuropsych and the health and behavior code. So thank you for that question. All right. So the feedback codes. United Behavioral Health asks you to bill 90834 for feedback. Check with your payers. Thanks, Gene. I agree. If United Behavioral Health tells you to use 90834 and it's in writing, use 90834. Do not use what I told you. In essence, I'm giving you this information as aspirational, national, and your individual contract may trump anything I say. So if they tell you, and it's in writing, that you should use 90834, please do so. And by the way, I didn't say it, but you may want to have documentation in your report. So for example, you may have a section that integrates all the data, and then you tell the patient, oh, guess what? You're not only depressed, but we have some depression. Excuse me, we have depression. We also have some dementia going on. So we'd like for you to see a psychiatrist as well as a neurologist. Well, the person then sort of falls apart, starts crying. I can't believe it. I live alone. Well, that is documentable information and should be included into your report. All right. This next question from Rachel. I'm not fully understanding how the tech codes include scoring. You mean the reimbursement was increased to capture that since no scoring hours can be charged? Yes. Rachel, let me explain to you how these codes were valued. A vignette was put together, and that vignette in this case says the test is administered by the technician, and that test is being scored by a technician. And then we send it to people like yourself with PhDs and PsyDs in the world of professional psychology and ask them, what is it that you think is involved in this service in terms of the amount of cognitive work, and people tell us X, Y, and Z, and then we value it. I mentioned, in case you forgot, that the old neuropsych codes without technician were reimbursed, roughly speaking, similar in scope to the new testing codes with technicians. So we haven't lost a great deal. In fact, we've gained the opportunity and probably lost 5 or 10% at that point. All right, let's take another question from Gene again. How do you bill for scoring, interpretation, report of psych testing administered by a technician? I thought we could use 102 for all of it, but now you're saying that 102 is only for face-to-face and 18 is for everything else. Okay, first of all, we're mixing. 102 is the psych testing, and 18 is, and actually is 102 is actually psych testing by technician, and 18 is neuropsych testing by professional, so we're mixing a lot. However, you should use 102 for time that's only face-to-face, but if you're going to integrate it with other information, which I hope you do, you would bill that as 101. So 102 is technician code, so is 119. That's only face-to-face. I hope you got that. If not, please send me another question, and we'll attend to you as well. All right. Terry, all right. Is there any movement towards getting H&B approved for dementia as a medical diagnosis? Medicare in New York does not allow such a thing because dementia codes are considered mental health. Well, several things. Dementia is really problematic, or complex, I should say, in the sense that if you use DSM, it's code XYZ, like 290.10, but you can use, for example, memory problems, which is a different code, it's an ICD code, or you could use Alzheimer's, which is also an ICD. So it depends. Now, if you, well, I'm blocking in essence what I was going to say, and that is I happen to know the medical directors for both of the Blue Cross Blue Shield and carriers that involve Medicare, but one of the problems I see is that you may just want to use the ICD diagnosis in this case and not DSM. See whether that you will get that. Okay, you will get the slides on video. I'm not sure that.
Trash.
Okay, all right. Let's go on to Jason. I will be completing pre-surgical neuropsych evaluations and epilepsy valves, WADA phase 2, language mapping on separate occasions over a period that could only be a few months within the same individual. With 118 be acceptable use in each of those occasions? Yes. Now here's the problem, okay? The problem is that one could argue that's the same disease, but you're measuring the same disease from different angles. So what I would do if I was you is I would be very careful, Jason. And by that I mean I would make sure that under your reason for activity that you state very, very clearly what is it that you were doing in each and every time. And why is it that you have to do it repeated? Because otherwise one could argue, hey, we have epilepsy, why are we doing 1-8 all these times? By the way, we have an fMRI code as well that's in my slide set. So good luck to you. And I guess we can call you the walrus according to your the picture beside your name. All right, so let's take this question from from Gene. Type of Marie on 102 and 118. It should all have been 102 and 101. So all interpretation is done under 101. Yes, that's correct. However, you say so all interpretation report a technician, not necessarily all, because the individual interpretation of a singular test is basically a 101 activity, and it should be done. For example, the IQ is X. Now, the 10 that's reported under 102. The comprehensive interpretation of what that IQ is going to be captured under 102. Okay. You keep mentioning integration of other sources. I appreciate that. Yeah, even whether it's integration of other sources or, for that matter, individual tests. All right, let's take a question from Melissa. I was told by an institution that I do not need to participate in the PQRS individually as my institution is part of ACO and reported quality measures at that level, and as such, we are exempt from the penalty. Is that accurate? I don't know the answer to your question, but here's what I would do. I would get a memo from your chief executive officer or the chief medical officer or CEO for your company to make sure that indeed if you do get fined later on, that you're covered. Now, another question, especially with this day and age that this is so messy, maybe some of us are not going to stay with the organizations that we started working on. So the question you might have, in addition to the one that you asked, is if I go on my own and I was not part of a PQRS system, will I be penalized? So that may be worth you making a different phone call to the carrier as well. All right, so let's take another question from Jason. In the case of WADA, ECOG, language map with HMB 150 be appropriate because I'm observing? Oh yeah, I think that I think that you can use psychophysiological monitoring or an HMB code. In essence, what I'm saying in a nice way is that people should feel comfortable and jumping off from the neuropsych testing codes to the HMB codes. I think we do that very infrequently, and I think the HMB codes are really intended for that kind of situation. All right. I think we covered all your questions at this particular point. Well, thanks a lot, folks. Appreciate you joining us this evening. And let's see. All right. So here I am again. Thanks again to you guys. I hope to see some of you at APA, and if not, I'll see the rest of you at NAN. Thanks, and good evening. Bye-bye.